All right, chapter 13 for exercise programming for special populations. We are talking to the ladies. All right, here we go. Female specific conditions. So we start with the female athlete triad. Again, this isn't like a huge thing that we see a lot of. It does happen. But again, if you work with female athletes, you need to be aware of this. And at least be aware, especially if you're some type of coach. These are things that you may have to deal with. And again, it's a it's not common, but over the years it has become a bit more increasingly common. Okay. Um, so it's an interrelationship between energy availability, menstrual function, and bone function. And the way that this happens is you have a female athlete who has an eating disorder, which causes her to be unhealthy. Body fat percentage and weight and everything drop so far below because they're not eating and not getting the nutrients they need that they become amenorrheic, right? And they're not having normal menstrual cycles, and also they're pulling calcium and other minerals from the bones, and so they have a large decrease in bone mineral density. And again, shouldn't never see that with athletes, and they become osteoporotic. Okay. Um, so risk factors for developing the female athlete triad include playing a sport that specifically requires body weight to be monitored, social isolation, exercising more than necessary for a sport, pressure to feel the need to win, punitive consequences for body weight gain, and having parents or coaches that are controlling or overbearing. So again, um, you think of powerlifting, right? So women in powerlifting are probably not likely to get this. Unless you have a female power lifter that realizes that if she can get her weight down far enough and somehow try to keep her strength gains and compete at lower levels, then yeah. But again, you see such a decline in your strength. You would think an athlete would recognize that strategy doesn't work so much. You again, a lot of people think, oh, that it's got to be fighting sports. Well, not typically, not fighting sports either, because again, they try to cut down right before the actual events, right? Again, you need your strength, you need your power, you need all those things. So typically the crash diet stuff happens only for a small time prior to the event. They weigh in, they fight, they beef back up, right? Same with guys and girls. um, where we typically see this is things like distance running, cycling, swimming, anything where the lighter you are, the better the outcome theoretically. Okay, and I say that theoretically, right? There's a point at which, yes, if you have a lot of excess weight, right, that's a lot of weight you got to carry around. So the thought is, well, okay, if I clean up my diet, I lose some weight, I become lighter. Now, and this is just not even, if we don't even take in consideration of the muscular function of your body getting any better, or the cardiovascular functions of your body getting any better. So those things hold steady, but you lose excess weight. Well, now you're lighter. Your body at the same workload could carry much lighter body much faster and further, so to speak, right? So that part makes sense. The problem is there's that level of, like you're an excess body weight. Here's this optimal level, and you drop. And then once you're in here, things should be good. But the problem is they start to see some success in here, and then they drop down here, and then you're at the same problems you were up here, because down here the body starts to deteriorate and your performance drops off again. Okay. But usually here's the reason people think, okay, well, wouldn't they just readjust? Um, Eating disorder is a psychological issue. Once you've created that, it's not something that most people can just stop, right? You look at it like any other mental disorder that somebody might have that they've created within themselves. Like, I mean, anything from alcoholism to drug abuse to anything else. At first it's, maybe it's like controlled decisions, but after a while it's not, and that's what eating disorders are. And so again, that's why it's so hard um, to curve that, right? So that's just from the sport part. Now, when you have folks have poor coaching where the coaches are like, you got to get your weight down, you got to get your weight down, they're not talking to them about, getting to the good optimal range. They're not talking to them about, working out, doing their, doing their due diligence with the training and the eating and all that. And they're just, they're so focused on weight. Or you have parents that are so focused on weight again. Unfortunately, in a lot of times in sports, we don't really have a whole lot of qualified coaches out there. You think about the number of athletes that are in junior high sports, and then the number of athletes in high school sports. It's bad, bad coaching out there, and especially in sports like, like if you think, like sports like distance running. A lot of times, if you didn't have like a good distance runner that's a teacher that wants to be a coach, in a high school or a junior high, sometimes they'll just grab somebody and just be like, hey, you want to make a little bit of extra money on the side by coaching, because they get a stipend, and they're like, sure, well, they don't, the sports that make money like football and basketball and things like that, they tend to, those are the sports people want to coach. And then sometimes these sports like the long distance running, again, I was a long distance runner, for your, I still run long distance. You know, I'm not saying it's not an important sport, but when it comes to the hierarchy of sports that pay off based on crowd attendance and things like that, and based on popularity, it's not up there. Therefore, a lot of times you get unqualified coaches. Again, parents most of the time have no freaking clue what they're talking about when it comes to sports, right? And so if you have an overbearing parent that wants success for their kids, to a point that it's too much, and they get in their head, they may push the kid overboard, right? And again, it's a bad process. Now, why don't we ever talk about the male athlete triad? We don't see it. Eating disorders in general are only like a small percentage. I'm not sure. I think the last statistic I saw, only 5% of our population it has eating disorders. It's mostly amongst middle class to upper middle class white females. We hardly ever see it in any of the other ethnicities. And it's minute to the point when you look at other ethnicities, or if you look at males in general. Statistically, it's not even worth talking about. I mean, that's how rare it is in those instances. So, you're looking at like like if 5% of our total population has an eating disorder, and 99.9% of that are white females within the upper middle class and middle class group. The whole small percentage after that, so you're looking at, less than 1% of 5%, population, makes up other females and males. So that's why you don't see it talked about very much within the male population, or you don't see it talked about that at all. Hardly talk about it with other ethnicity. It just yeah, it's almost exclusively within that particular group. And so again, probably any videos or any reading material or anything else that you'll see on this, when you're looking at eating disorders, you're going to see that portrayed within that particular population. You won't really see any other populations brought into it. Now, that being said, eating disorders are clinical. Disordered eating is a whole different thing. With the rise in fad diets and all the garbage out there trying to get people to eat this, eat that, do these shakes instead of eating, going keto, going intermittent fasting. And again, can some people do those things in a healthy way? Yeah, sure. But most people go to the extremes. They have no idea what they're doing. They create, really bad eating patterns. Yeah, disordered eating's all over the place. Trust me. But eating disorders are still a very small percentage, although I do believe disordered eating leads people to eating disorders. And so it's definitely been on the rise, over the last few decades. Okay. So they put disordered eating on here, but it's really, you've got to get a clinical order. Eating disorder is usually how they describe this, right? Menstrual cycle dysfunction, loss of bone mass, and then you have your female athlete triad. I actually had when I was in my PhD, Dr. Mitch Raw is one of the foremost experts on this. I'm not really sure I can't remember. He told me one time, I was like, how'd you get so into this type of research? And he told me one time he's a professor out in California. And he just was fascinated by it. And he's done a lot of work on it. So, if you read any of his papers, they're really enlightening. So, yeah, I would definitely look for his research. History of menstrual, so early detection signs. History of menstrual irregularities and amenorrhea, history of stress fractures, history of critical comments about eating or weight from parent, coach, or teammate, or even from them. Like if they, like a lot of times when you hear people talk about their eating, they don't really, if they tend to have more negative comments about food, or or an obsession. Notice an obsession of like what they eat, or more in particular what they won't eat. History of depression, history of dieting, all these things are early detection signs. Okay. Personality factors, perfectionist or obsessiveness, again, puts you at a high risk for these type of eating disorders, which again, in a female athlete, then you would have the whole trifecta. Pressure to lose weight or frequent weight cycling. Again, that's not only in athletes. We see this a lot in we see this a lot in I'd say young women. Actually, I'd even say middle-aged young women. I definitely have seen an increase in this in the male population over the years too. With the advent of um, Facebook and Instagram and everything else, and the amount of quote unquote fitness pros out there and quote unquote fitness models out there. And again, I always challenge folks. I'm like, if you notice somebody only like all their pictures seem to be very similar, and it looks like they may have taken like changed a bunch of outfits, but it looks like they're in the same location and they've taken all these pictures, like all throughout the year, more than likely they got really, really, jacked, dieted like crazy to get to that point. They took all those pictures. They're probably more in a normal range if you saw them on the street type of thing. Most people don't, have veins on top of veins on top of veins all the time, right? It's pretty rare that some people can do that and be in a healthy state. It's not something that typically happens. Early start of sport specific training. Overtraining, again, just they're obsessive, right? So not only are they eating disorders, but they won't stop training. They won't let their body rest and recover. And reoccurrent and non-healing injuries, right? Their body's void of nutrients. They're overtraining. Their body just will not fix itself. They're not allowing it to. Common signs and symptoms: irregular or absent menstrual cycles, constant feeling of tiredness, fatigue, sleeping disorders, stress fractures, recurrent injuries. Another thing is you as a coach will notice their performance is going to get bad. Their performance is going to go down. They're not going to perform at whatever level that they were performing before they dropped into that. They dropped into the triad, right? Again, self-restricted food consumption, constant effort to be thinner, eating less food than what's needed in an effort to improve performance or physical appearance, cold hands and feet. Again, cold hands and feet, poor circulation. After age 11 or 12, low energy availability or energy deficiency disrupts proper functioning of the reproductive system in girls, resulting in irregular or less frequent menstrual cycles. 3 or more menstrual cycles missed consecutively is considered amenorrhea. Disruptive menstrual cycles result in less estrogen being produced. Osteoporosis is progressive bone disease that is characterized by a decrease in bone mass or bone mineral density. Estrogen loss triggers bone loss. Osteopenia, if more long-term or serious, it leads to osteoporosis. Osteopenia occurs more in postmenopausal women because the loss of estrogen and may worsen by being considered sedentary, consumption of too much alcohol, smoking, or prolonged use of glucocorticoid medicines. Again, this should be more common, osteopenia, osteoporosis in older populations, based on the way that, again, our population lives its life. This is not stuff you should be seeing in like 14, 15-year-old girls or 20-year-old girls, right? There's an imbalance in the bone remodeling process secondary to decreased energy availability. Loss of estrogen eventually leads to brittle bones that are more likely to be damaged both during activity and later in life as bone loss progresses. Loss of bone mass is also related to deficiencies in consumption of calcium and vitamin D. Diagnostic Statistical Manual of Mental Disorders, the DSM-5, defines feeding and eating disorders. These are anorexia nervosa, bulimia nervosa, pica, rumination disorders, avoidant restrictive food intake disorders, and other specified feeding or eating disorders. So again, there's not everybody falls under anorexia, not everybody falls under bulimia, and so we've created other categories that they can fall under. Again, some of them aren't like full diagnostics or full, like a doctor may not diagnose, they'll say you have a disordered eating pattern rather than an eating disorder. But again, we're starting to see more and more, not full blown one or the other, really. And so again, we're still seeing health effects from these other bad eating patterns. And so again, we've, the scope of this has grown. Both biological and environmental variables seem to play a role in causing feeding and eating disorders. Medical treatments are effective and can include changes in diet. Psychological treatments, they're going to need psychological treatments. I mean, you think about in normal, like just think about yourself, think about people that you talk to and work with, and any conversations you've had about diets, or the way they look or anything else. I mean, how many times have you met somebody that from all appearance that you can see, they look perfectly healthy, they're fine, but maybe they look really good. And in their mind, they don't see that, right? And they're like, I need to diet, I need to lose this, I need to, and you're thinking, you're like, man, I wish I could look like that, again, in their mind, they don't see what everybody else sees, right? There's some psychological stuff going on there, right? And prescription meds can also help. After about 5 years of treatment, approximately 70% of those with anorexia nervosa and 50% of bulimia nervosa recover. Again, binge eating disorder recovery occurs in 20 to 60% of those affected. Again, I mean, it's, 5 years of treatment, right? It is a deeply psychological problem. Okay. It's not one of those things you as a coach, you're going to help them fix it. It's not going to happen. You're going to see it. you're going to address it, and you're going to recommend them to go see a doc. Okay. Anorexia nervosa is characterized by low body weight, obsessing about body shape, size, including desire to look thin, fear of gaining any body weight, and restrictive eating behaviors. Behaviors include weighing oneself frequently, using laxative, forcing oneself to vomit, exercising excessively, and eating small amounts of food. Again, a lot of people say, "Oh, isn't the vomiting a bulimia thing?" It is. We'll get to that in a second. So is laxatives and so on and so forth. Even exercise excessively, you'll see the difference. The main characteristic that defines anorexia nervosa is that somebody's below body weight and they will do anything to refuse to get into the normal body weight range. So just they'll use whatever means necessary not to cross into the threshold that, like, someone's like, you need to be up here. They don't want to gain any weight. They refuse to gain any weight, even if it's like, even if they're dying, they refuse to gain any weight. That's what it is. Okay. And again, it arises from a complex interaction of psychological, behavioral, biological, and social variables. Some signs of anorexia nervosa can include brittle hair, nails, dry or yellowish skin, constipation, muscle wasting, weakness, low blood pressure, sluggishness, reduced body temp, making one feel cold. Greater risk of heart damage, increases the risk of heart attack, heart-related problems, and death. Medical treatments for anorexia nervosa include restoring the woman to a healthy body weight, treating any psychological issues, reducing or eliminating behaviors or thoughts that can lead to relapse. Bulimia is repeated patterns characterized by binge eating, followed by other behaviors to compensate for the overeating. And we call that purging. So vomiting, laxatives, diuretics, fasting, excessive exercise, or a combination of all. So again, you can have an overweight bulimic. You can have an underweight bulimic. You cannot have an overweight anorexic. If you want to know the true difference between the two. Again, you can have a bulimic that's in normal weight range. An anorexic would be below that. So again, you can find bulimics in like obesity, overweight, normal weight, and underweight. It's just the patterns of their behaviors. Okay. Um, Again, some of them will continue to overeat more than they can purge. Therefore, they may continue to gain weight, or they may stay the same, or whatever it is. So yeah, I know a lot of folks usually have questions between those two because, before, I know, a lot of times when you take like a simple class, maybe in high school or like early college, they'll go over these two and they'll say, yeah, anorexics don't eat, bulimics eat and puke, right? And that's pretty much all they tell you, and that's not true. I mean, it is and it isn't. It's a really simplified characteristic, but yes, anorexics can use bulimia or bulimic patterns, so to speak. But those that are just bulimic may be not considered anorexic. Okay. So there's 5 criteria for binge eating disorders: eating in a discrete period of time, larger than normal amounts of food, and similar time, lack of control over eating during those episodes. Then eating episodes that are associated with 3 or more of the following: eating faster than normal, eating until uncomfortably satiated, eating large amounts of food when not hungry, eating alone due to embarrassment about amount of food consumed, or feeling disgusted with oneself, depressed, or guilty after eating. Now, how many of you guys have ever felt that last line, disgusted with oneself, depressed, or guilty after eating? I couldn't tell you how many people that I've talked to or in conversation, they're like, oh, I was, so ashamed of, like I ate way too much, things like that. Like I said, our mentality when it comes to food and things like that, and the relationships that people now have with food, you hear this whole food relationship thing, you may not really understand it. But people have really unhealthy, like you can have unhealthy relationships with people. You can have very unhealthy relationships with food. where you're like, oh, that food's bad for me, or this is, or like you feel these things, like you look at you get depressed because you're like, I can't believe I overate again. I can't believe I did that. I can't believe, I was doing so good. You know, you feel guilty, right? These are things that are becoming more normal. And again, these are patterns that can lead down to really poor eating behaviors. Okay. Um, Again, binge eating disorders have 5 criteria: feelings of significant emotional or psychological distress or anxiety regarding binge eating episodes that occur at least once a week for 3 months, binge eating not associated with repeated use of an inappropriate compensatory behavior, as is observed in bulimia nervosa, vomiting using laxatives or exercising excessively, and does not occur exclusively during the course of bulimia nervosa or anorexia nervosa. Other specified feeding or eating disorders include an eating or feeding disorder not fully meeting all the criteria, right, of either anorexia, bulimia, or binge eating disorders. Again, you could have atypical anorexia, atypical bulimia, binge eating, both with low frequency or limited duration, purging disorders, night eating syndrome. There's some other ones too. Before we get to the really weird one here in a sec, um, one of the things that for years and years we never really classified, but again, it kind of goes along with the binge eating that we see, is that binge eating doesn't only occur in people trying to lose weight and then they lose control, then they purge and do all that. But binge eating we see on the other side with folks that are constantly gaining, right? So overeating and binge eating in itself has been classified in not recent years, but when you look at the scope of nutrition, and us talking about these particular subjects, it is somewhat recent. That it's the other end of the spectrum has now been classified as an eating disorder. And again, it's important to understand because that end of the spectrum affects a lot of people. Like if you think of most people that are overweight and obese, that is their main issue that they have, right? Is that they eat more than they need, they overeat or they binge eat. They have way too many binge eating episodes during a week and so on and so forth. And the reason I bring this up, not to shame anybody that might find themselves on the far end of the spectrum, but again, I want you to understand the complication of the psychological ramifications that people have when it comes to food. Um, and when you're working with clients that are trying to lose weight, because if you work in fitness, 99% of your clients are coming to you because they want to lose weight, right? So taking that consideration, understand that it's not as simple as, oh, we've got to expend more calories than you're taking in. We'll see a decrease. I mean, simplest biological term, yes, but the psychological part of that is the difficult part. Okay. And so you've got to understand that. So you've got to come to them with an understanding that they have some psychological issues when it comes to trying to figure out how to balance their energy. Okay. It's not as simple as we like to make it out to be. Okay. All right. So now we're getting into kind of this is one of those that you may have seen like some TV specials on people that have this, but pica, described as an appetite for non-nutritive substances. They'll eat things like paper, chalk, sand. Again, these things can cause gastrointestinal distress, blockages, cause major health issues. Rumination disorder is effortless regurgitation following most meals induced by involuntary contraction of the abdominal muscle, where there's no retching, nausea, heartburn, odor, abdominal pain associated with the regurgitation. Right. It's almost like, babies, a lot of times babies, when you feed babies, they just burp stuff up, if they eat too quick, it just burps up. Sort of along those same lines. They just, it's like they eat and then here it goes. Right. Avoidant restrictive food intake disorder, also known as selective eating disorders, characterized by prevention of consuming certain types of food. Oh my gosh, how many of you they fall under this one or know somebody falls under this one, right? They won't eat this, they won't eat that. Why? Because it'll make them fat, right? Or they think it's going to make them fat, right? Again, that is disorder. Again, this is an eating disorder, but it's disordered eating pattern, right? So any diet that tells you you can't eat something falls under this. Change in eating can be caused by significant weight loss, nutrition deficiency, use of feeding tube or dietary supplements, or significant psychosocial interference. Medications, no medications are prescribed to women or girls because she has been diagnosed with her physician or other healthcare professional with female athlete triad. These may be prescribed for conditions within the triad, estrogen, again, if they're having menstrual dysfunction, risk for osteoporosis, can improve bone mineral retention, antidepressants for women who have a diagnosed eating disorder. Again, exercise. One of the issues that we run into here is that they may be over exercising. So sometimes they're going to be required for a period of time, you know, especially as an athlete, they got to take some time off. But again, obvious outcomes of exercise is caloric expenditure and potential impact that is made on overall caloric balance. Effects of a female athlete triad can be exacerbated even by small amounts of caloric expenditure. So again, you know, most you've seen everything exercise good. Well, again, exercise is going to be good for them in the long run, but they may have to take a time out, right? Energy availability can improve in matters of days or weeks with return to normal menstrual status thereafter. Recovery of lost bone mineral density, normal estrogen levels may take up to several years. And returning to the last body weight where normal menses was last observed should be a benchmark for normal energy status. Again, hopefully, you know, once they hit all these things, then they should be able to start training a bit again. Again, their exercise prescription will not be that to train them at a high level for a while. You know, it's just going to be to, you know, get them stronger, get them healthier, get them mentally healthy. You know, have a positive and healthy outlook on exercise, and not as a tool to their demise. You know, again, with obsessive and perfectionists, that they may need to see the exercise as not just a tool for, you know, their sport performance. You know, and so again, they may be doing exercise, and again, you know, think of a distance runner. You may keep them away from cardio for a while. You may try to beef them up on the muscle front, right? We may be in the gym lifting, just to give them a whole different prescription. And again, you know, that's going to help them with, you know, the muscle wasting they went through, the bone mineral density. You know, it's going to be for health reasons, not for performance. It's further recommended that the calculated body mass index be increased to greater than or equal to 18.5. Increased energy intake should be accompanied by increased vitamin D, calcium consumption. Resistance training will help to improve bone mass, muscle strength. That's what I said. But high impact activities should be avoided. Again, they have weak bones. Right? Prevention, healthy attitude toward exercise and food with robust pre-participation screening is the first step. Again, people don't have healthy attitudes towards exercise and food a lot of times, food more than exercise. So, you know, it's a good idea as a coach to have some good counselors come in that understand these type of things, to come talk to your teams, and, you know, even have psychologists on hand that they're always able to talk to. Team approach involving coaches, exercise professionals, medical personnel, psychologists is recommended to avoid personnel operating out of their scope of practice. Again, you're not a psychologist, therefore you're not going to be the one that's going to coach them out of it. Integrated approach is outside the scope of practice of a single certified exercise professional. So best practices refer to licensed professional, physician, registered dietitian, psychologist, with consultation with the coach, right? So it's going to be a team approach. Okay. So 5 strategies for prevention: keep a written record of monthly menstrual cycle and discuss with the physician or other healthcare professional if any changes in the menstrual cycle occurs. Keep track of daily caloric consumption in order to maintain energy availability to the body and to maintain body weight. Eat every 3 to 4 hours with 3 meals a day and at least 2 snacks to provide energy for exercise and recovery from exercise. Consider snacks as mini meal with constituents that are nutritious and healthy and that fit into the person's lifestyle. And keep a written record of daily exercise, including mode, type, time, and intensity. Again, are these five like you have to do this? No, some of these may actually, like in some obsessive folks, or like it may cause more, in certain folks, these things may cause some harm, is what I'm saying. I'm not going to go all the way into it, but sometimes record keeping for somebody that's obsessive about things can also become an issue too. So yeah, again, this is just a good idea type of thing for a lot of folks, but it may not work for your athlete, right? Pregnancy, postpartum. Being physically active during pregnancy poses little risk to the mother. If there are no pregnancy-related complications during pregnancy, exercise can help to maintain health, fitness levels, assist with weight management, reduce incidence of gestational diabetes, and improve psychological health, right? Your their body's going through a very rapid change in 9 months, and that can have some psychological health issues along as well. The stress of the upcoming baby, all those things. So again, exercise will have some really positive effects. Being physically active during postpartum can assist in weight loss, improve fitness levels, and psychological well-being without altering milk production necessary for breastfeeding as well. Pregnancy hormones, including estrogen, progesterone, human chorionic gonadotropin, human placental lactogen, relaxin, and prolactin. Estrogen has an anabolic effect on the body to promote breast tissue development, blood vessel enlargement, as well as regulate levels of progesterone. These hormones increase 100-fold or 10 to 15-fold during pregnancy, respectively. Human placental lactogen can function like growth hormone to alter metabolic properties to deliver more energy to the grown baby. Fat breakdown is also increased to deliver more free fatty acids to the baby. Without appropriate caloric intake, hypoglycemia may occur, resulting in nausea, dizziness, and fatigue. Weight gain during pregnancy is necessary, but excessive weight gain can increase obesity-related disease risks. Table 13.2 will outline the recommendations for weight gain during pregnancy. Low back pain is related in part to the weight gain and is a common symptom with pregnancy. Hormone relaxin may contribute to low back pain. It may also affect other joints in the body, may lead to inflammation and pain. Postpartum is a period immediately following the birth through about 6 weeks after delivery. During breastfeeding, menstrual cycle, and by association, menses may not return to normal levels until 6 to 9 months postpartum. During the postpartum period, musculoskeletal changes in the pelvic floor, muscles, and pubic symphysis continue. Pregnant women might take over-the-counter remedies to alleviate various side effects of being pregnant. The side effects can include headaches, constipation, hemorrhoids, diarrhea, nausea, bloating, heartburn. Prenatal vitamin and mineral supplementation are also common, including folic acid, calcium, iron to prevent developmental problems. Exercise will promote muscle strength and endurance, increase energy, improve body posture, sleep, overall mood, decrease backaches, bloating, swelling, and constipation, improves ability to manage labor, allows for an easier return to pre-pregnancy body shape. And aerobic exercise training can also reduce the incidence of gestational diabetes by about 55%. While most researchers agree that exercise during pregnancy is safe for both mother and child, there is a disagreement on the benefits in terms of preventing preeclampsia, gestational diabetes, and perinatal depression. Elevated maximal oxygen capacity postpartum, lower total body fat, and more energy expenditure during moderate exercises are other results of aerobic exercise. Recommendations are in 13.3. Again, 150 minutes of moderate intense aerobic activity per week is recommended. Healthy women who already do vigorous intensity aerobic activities can continue doing so during and after their pregnancy, provided they stay healthy and discuss with their healthcare providers how and when activities should be adjusted over time. So it's kind of speeding up to get to this point, because again, it's like, yeah, they can exercise, okay? But when you're looking at like say somebody that trains for marathons or something like that, they can continue doing that. I've actually seen women that got pregnancy during their training and still trained and ran their marathon. This is not the time to take somebody that's sedentary and start working their way up to in like a high intensity workout, right? I mean, now you could take someone, they got pregnant, and they're like, oh man, I was really wanting to start working out. That's fine, but you can take a very gradual approach with them, like you would anybody that hasn't worked out before, and just again make sure that they're healthy throughout the process as they start their training, right? You may go from like light to moderate over that time, possibly. They may stay in the light. Again, it just depends on the person, right? So again, that's what you're going to see. Those who were previously sedentary engaged in only moderate should not engage in vigorous, right? And again, we don't want to, it's not the time to try to get in shape. Okay. RPA of 13 to 14 may be appropriate, more appropriate than using the heart rate to monitor intensity. Resistance training can be done 2 to 3 days a week, 60 to 8% of a 10 rep max, perform 12 to 15 reps, not the reps. They don't want to go to fatigue. Lighter resistance is recommended after 28 weeks of the pregnancy. Okay. Stop exercise if any of these things happen: vaginal bleeding, shortness of breath before exercise exertion, dizziness, headache, chest pain, muscle weakness, calf pain or swelling, preterm labor, decreased fetal movements, or amniotic fluid leakage. Exercise in the heat is not recommended. Stay hydrated. Supine exercise is contraindicated after the first trimester, and activity that risks abdominal trauma should be avoided. Again, boxing class or sparring and stuff would not be recommended. Okay. Postpartum exercise should be resumed gradually to allow proper readaptation to activity. Pelvic floor exercises during pregnancy and postpartum can assist the restoration of the musculoskeletal function of the pelvic floor muscles and alleviate urinary and anal incontinence, pelvic organ prolapse, sexual dysfunction, and chronic pain. During menopause, hormone levels, all right, we went from, I was just speeding through there. Now we're in menopause and postmenopause. During menopause, hormone levels can change dramatically, especially decreases in estrogen. Changes bring about loss of bone mineral density, can lead to eventual osteoporosis, increased risk of bone fractures. Regular exercise can have a protective effect on bone in this population. Menopause is characterized by the loss of ovarian follicular function, subsequent cessation of childbearing. Transition period between childbearing years and menopause is called perimenopause, lasts 5 to 8 years. Symptoms during perimenopause include rapid heart rate, vasomotor inability to regulate body temp, mood changes, depression, irritability, anxiety, sleep disturbances, and cognitive issues such as lack of focus or concentration. Postmenopause is defined as no menses for a 12 months period in which a woman is not pregnant or lactating. Some symptoms during this time include night sweats, back and muscle pains, loss of lean muscle mass, weight gain, increase in visceral abdominal fat, bloating, indigestion, constipation, heart palpitations, or a combination of any of them. Osteoporosis makes bones more porous and thus fragile due to the negative changes in estrogen, loss of calcium. It's most common in postmenopausal women. Other risk factors include being small boned of Caucasian or Asian descent over age 55, family history, osteoporosis or hip fractures, physical inactivity, diet low in calcium D, vitamin D, smoking, and high consumption of alcohol. Bone is undergoing constant renewal called remodeling that consists of reabsorption, which is a breakdown or removal, and formation growth. There's increased reabsorption or decrease of growth, as during menopause, weaker bones will develop over time. Medications for menopause-related osteoporosis, there's two categories: anti-reabsorptive medicines and anabolic medications. The goal of anti-reabsorptive medicines is to prevent bone loss, lower risk of breaking bones, and anabolic medication is to increase the rate of bone formation and thus bone strength. Medications for menopausal symptoms. Hormone replacement therapy can reduce frequency and severity of the hot flashes, lessen irritability, sleep disorders, increase skin collagens, assist in decreasing postmenopausal osteoporosis by slowing down bone loss and promoting increase in bone density. Side effects can include headaches, nausea, fluid retention, weight gain, breast tenderness. More serious side effects include increased risk of breast cancer, heart disease, stroke, blood clots, severity of which is affected by timing and duration of the treatment. Low doses of medications that are commonly used as antidepressants may reduce frequency and severity of hot flashes. Also, paracetamol and conjugated estrogens, bazendoxifene formula have been developed specifically to treat hot flashes. Exercise recommendations are all in 13.4, but regular exercise can alleviate the more common symptoms in menopausal women by improving cardiorespiratory system, psychological health, overall quality of life. Aerobics, resistance training, and mineral supplementation can improve blood lipids, muscular strength, and increase bone mass or decrease the rate at which they lose it at least. Some evidence suggests that walking, jogging, running alone may not adequately improve bone mass, making resistance training all the more important provided proper progression is followed, about 5% increase per week. Resistance training should be done at intensities of 40-60% of the 1 rep max, 1 to 2 sets of 15-20 reps for beginners, and progress slowly to 80-85%. 1 rep max to stimulate bone growth. Exercise should be weight bearing. Power training may be beneficial. Spine specific exercises are also recommended. Look at figures 13.2 to 13.6. Anytime you're loading the spine is great in this population, right? So spine specific, these are again good exercises, especially with that older population. Again, these are great beginners exercises. You can progress. And that's it. If you have any questions, comments, concerns, please let me know. That is the last chapter of this book. So I'll see you guys in the next class.